Good afternoon and happy Friday. We're just going to wait a few more minutes for everybody to join and then we'll get started. Thank you. Hi, I'm really sorry for the delay. We're just waiting for our keynote speaker to log in. So it'll be just another minute. Thanks. Okay, really sorry for the delay today. Hi, I'm Donna Cross, a faculty member of the Department of Radiology and Imaging Sciences here at the University of Utah. It's our pleasure to present you the third and final day of the virtual Imaging Elevated Symposium. Each year, we invite exciting speakers from around the world to discuss the latest and greatest research and clinical techniques they are pioneering. We also invite emerging investigators in our field. Our goal is to encourage our emerging investigators and all participants in the symposium to make diverse connections and to help lead us into new frontiers for imaging. I would like to thank all panelists and attendees from the last 2 days for some great talks and discussions. I particularly love Dr. Blumke's story from the first day about Arnold Schwarzenegger's work ethic. If you've missed it, I think you can go back and view it on YouTube. With that, we'll move on to our program for today. And please remember for the question and answer to use the Q&A button on your controls rather than the chat. So with that, I'd like to introduce our keynote speaker, Dr. Greg Zacharchuk. Dr. Zacharchuk is a professor of radiology at Stanford University in the Division of Neuroimaging. He received his MD from Harvard Medical School and his PhD from Harvard-MIT Health Sciences and Technology Program, and clinical radiology and neuroradiology training at UCSF. He is a clinical neuroradiologist and directs the Center for Advanced Functional Neuroimaging at Stanford University, where his research focuses on advanced medical imaging techniques and algorithms, including AI, with the goal of alleviating the burden of neurological disease. He is a member of the editorial board of Radiology, the Journal of Magnetic Resonance Imaging, and the American Journal of Neuroradiology. He is the president-elect of the American Society of Functional Neuroradiology and chaired both 2018 machine learning workshops sponsored by ISMRM. He was recently elected as a fellow of the American Institute for Medical and Biological Engineering. And with that, I would like to welcome Dr. Zacharchuk to give our keynote speakers lecture today. Thank you.
Thank you so much, Donna. I really appreciate it. I'm sorry it was very challenging to get the web link, but now we're on and ready to go. I'm very excited to give this talk and want to thank you very much for inviting me. And I will just share my screen and we will talk about how AI is going to change radiology. Let's see, share screen. I think you have to give me that power, Donna. I have a sign that says the host has disabled attendee screen sharing.
Go ahead and try that again.
Okay, looks good. All right, so here are my slides. Let's see. Can everyone see that okay? Okay, I'm not hearing any complaints, so I'm just going to move forward. So thanks again to the organizers. I'm very excited about presenting this to you. This is a picture of our hospital, which opened just about a half year ago. And I would just want to start by acknowledging that 2020 has not been the greatest of years for us. This is actually what our hospital looked like. Let me see if I can actually advance. This is what our hospital looked like a couple weeks ago when we had very severe wildfires out in California. And although we're doing better, it remains kind of a constant problem for us. I would just say that, you guys in Utah certainly have your own issues, and I just kind of stumbled across this this morning, and I thought I would just share it with you. So no part of the country seems to be immune from the horrors of 2020. All right, so here are my disclosures. I do have one additional disclosure that's not on this slide, and that is during this talk, I will be flashing subliminal messages to you. So just keep an eye out for those as we go along. Okay, so I want to start off by talking about a grand overview of radiology and where the big inflection points have been. Obviously, the field started in 1895 when X-rays were discovered and harnessed for medical use. And then things progressed, for a while until we got to angiography, which is when Moniz showed that you could inject contrast agents into vessels and provide images of the vasculature. And then there was kind of a long stretch when all we had was plain film radiology and angiography until 1972, when we got our first chance to see inside the body in a cross-sectional way with CT. And in fact, MRI was also invented just about the same time, although it took a little longer to come into clinical practice. And I would say that the last major inflection point that we've seen is the widespread adoption of PACS and electronic medical records. And what I want to try to convince you today is that we're at another one of these inflection points. And I kind of dated it 2017 as the date when this really started to come into the public radiology consciousness. Okay, so I want to organize this talk really from the patient's perspective and talk about what happens when a study gets ordered. Typically, the patient will come to the scanner, they'll have their scan performed, the image acquisition will occur. There'll be some enhancement and visualization that may occur at the same time. We might do some post-processing type analytics, and eventually the goal is to use that to make a diagnosis, which then eventually will drive appropriate treatment. And I think that AI really impacts us at all of these areas. And I think the first thing that people think about when they think of AI is they think about interpretation. And that's certainly a very important part. But I also want to focus more upstream in this cascade. I want to talk about AI's impact on post-processing, on the actual reconstruction process itself. And I think we may have a talk later in the session about this. And in fact, even before imaging or during imaging, how can AI be used? And then finally, I would just like to sort of describe some new and different applications that AI has enabled that kind of cross many of these traditional barriers. Okay, so I want to start out by talking about image automation, sometimes called pre-voxel imaging. And I want to share with you this video that is of a scanner basically running itself. So we all understand the great progress that's has been made in autonomous vehicles. This is a driverless scanner. And this was developed specifically for cardiac MRI because cardiac MRI is a very challenging modality. And basically what this software does is run the scanner, evaluate the pictures, alter the scan planes in the appropriate positions to run the appropriate views that are required during a cardiac MRI. And this is really important because standardization is quite important. When I talk about all the other applications that I'll talk about today, they all start from the data. And if your data is not acquired in a very standard way, it will be very hard to apply any kind of algorithm to it in the future. So next, I want to focus a little longer on image reconstruction. And I want to share with you this article that was published about 10 years ago, focused on MRI. As you know, I'm very interested in MRI and in PET. And Bill Edelstein wrote this very nice paper where he came up with these pretty good MRI principles. And you can read them here, and I think we're doing quite well on most of them. But I would say the one that we're not doing very well on is this idea that examinations should be shorter. He says they should last 10 minutes, and there should be 5 minutes to get the patient on and off the table. And I would say that, since I've been involved with MRI, the length of a clinical MRI has been pretty much fixed at about, anywhere between 20 and 60 minutes, depending on the type of examination. But it really hasn't budged, despite the fact that we've had plenty of amazing hardware and software advances over the years. So I want to talk about some of the advances with AI that are going to allow us to get into this range. So I first want to show the principle using a method that's near and dear to my heart. I'm very interested in the measurement of cerebral blood flow and the use of a technique with MRI called arterial spin labeling, which basically labels blood magnetically in the neck and then images it when it reaches the brain. And if you set up everything correctly, you can get these beautiful maps of cerebral blood flow. But as anyone who has worked in the field will tell you, the real challenge is that this is a very low signal to noise type of study. It requires often a lot of signal averaging to build up enough signal to have an interpretable picture. So how would you use AI to address this? Well, here's an example. If I actually acquire multiple signal averages and get a very high quality image, it might look like this. This is an image of the brain blood flow. If I don't have that much time, I might spend a shorter amount of time, 2 minutes, and get an image that would be subdiagnostic. But maybe I could combine that image with other images that I acquire anyway during the scan and try to use an algorithm to predict the high quality image. And indeed, this is some of the work that Enhao Gong had worked on while he was a graduate student with me a couple of years ago. And what he showed was that you could in fact do this. You could reduce the time for scanning by about 4-fold, and meanwhile improve the SNR of the images when comparing to a gold standard by about 30%. So simple application, but very powerful for denoising. Many of the applications you'll see in this talk when we talk about creating new images from other images are using this structure called a UNET. And I'm not going to go into a lot of detail about how they work, but the basic idea is that this is a deep convolutional neural network where you can have multiple inputs coming into one side of the network. They pass through a lot of filter banks, a lot of nonlinear filters, and they try to predict an image. And this is a supervised learning method. So in this case, if we know what the image should look like, we can then compare it to what the algorithm has produced, and then we can use that to efficiently train this network. And I just want to leave you with the paradigm of sort of on the left side of this map is what you have, and on the right side of this structure is what you want. And let's just see how far we can go with that basic idea. So, we weren't the only ones to think about using MR for reconstruction. This is some work from NYU showing examples in the knee, just demonstrating from the left to the right some recent advances in MR, such as parallel imaging with compressed sensing, which improves image quality, but using a deep learning network to produce the image using a variational network actually demonstrates improved quality. I don't read a lot of knees in my normal practice, but I think that if I was going to read knees, I would want to read these far ones here on the right. Now, another application you can think of is not just denoising of images or reconstruction, but super resolution. So a lot of work has been done in the computer vision field over many years trying to learn how to produce higher resolution images. And this is just some work from Akshay Chowdhury, who's a new faculty member at Stanford, just demonstrating this applied to high resolution structural MRI, which is often too long to acquire during normal protocols. But if you could acquire it more quickly, such as the images on the left, this might end up being used more often. Okay, so what do these implications mean about hardware? So as I mentioned before, we've had a lot of great advances in MRI hardware over the last 10 to 20 years. And I think that's really emphasized by this very nice paper by the NIH group that showed if you took a standard high field scanner, all of the high performance coils, all of the bells and whistles, and all you did was reduce the field strength by about 2/3. I think they ramped it down to 0.5 Tesla. And what they showed was that the images were of surprisingly good quality, even at this lower field strength. And one of the things that you can do in this setting is to actually use the methods I've described before for denoising to actually improve the quality of images that are acquired at lower field. And this example is just a 1.5 T diffusion weighted image that we typically use for stroke. And this just shows what the image looks like on the left as acquired on the scanner, and on the right after going through a deep learning based algorithm for denoising. And you can see that there's really no reason we shouldn't be acquiring these every day. The quality is really very similar to what you might get at 3T. So my question really to the manufacturers is, is this the time when we start thinking about much lower performance devices, which are then corrected after the fact by software? And this could really make a big difference because, as you know, MRI is quite an expensive technology, but is tremendously useful. Okay, could we apply this to other modalities? Well, here's an example in whole body FDG PET. And again, the same principles apply. If you have a patient perhaps that is uncomfortable on the scanner, maybe they are in pain because they have a malignancy and they have bone metastases, or they can't keep their hands over their head for a long period of time. Could you think about having a reduced scan time? Well, you certainly could, but the images might look like the images in the middle here, which are noisier than you would typically get with a high resolution scanner. But again, using convolutional neural networks, what we've shown is that we can improve the quality of those images so that they're really almost indistinguishable from the longer scans. And this is just an example of a 4 times faster scan, but you can imagine, because PET is a camera, this would be very similar to the image you would get if you injected 4-fold less dose as well. And so this is one of the products that one of the companies I mentioned earlier, Subtle Medical, is working on. And actually, within the laboratory, we've been working at much more extreme dose reduction. And Kevin Chen, who will be speaking in the next section, will be giving you a talk about how this might be applied to amyloid imaging for dementia. So if you can go to very low dose, the next logical question is, could you go to 0 dose? And this is just an example of that. As I mentioned before, I'm very interested in blood flow imaging in the brain, and PET is the gold standard for that. However, there are MRI techniques like ASL that can estimate blood flow, but they tend to suffer abnormalities or errors, particularly in patients with slow flow regions. So the idea was, if we do simultaneous PET MRI, could we use the oxygen 15 water PET study, that's the gold standard, on the right part of that network, and then basically throw everything that we've acquired with the MRI that we think would be useful into a deep neural network to try to make this prediction. So I like to call this cross-modality contrast synthesis. We've seen this in other areas such as MRI to CT and the like. But I think the way we describe it internally often is 0 dose. And the question is, can you go to what we would call 0 dose PET imaging? And here are just some results. On the far right, this is the PET image, gold standard blood flow map. On the left here is the map you would get with standard MRI techniques. And you can see it's pretty good. It's a good start. But this is the error, right? This column represents the difference between those two maps. You can see if you do slightly more elaborate ASL, using multiple post-label delays, you can reduce that error somewhat, but you do far better if you use a deep neural network to do this type of cross-modality synthesis.
Okay.
So we're very excited about that. And once you can do something like this, it opens up new possibilities. So we've instituted this as a real-time mechanism on our scanner where if you perform the right sequences on MRI, you can produce a PET-like map as shown here on the right. And the thing that this does is really liberate the scan from centers that have PET. So now if you have an MRI scanner and you run these sequences, we can provide PET-like maps. And we're still in the process of trying to understand whether these are useful and how useful they are. So blood flow imaging is one thing that both MRI and PET can do. Let's talk about other radio tracers. This is FDG, the most common tracer, and in the brain it's often used to detect recurrence of brain tumors. And we decided that we would try to do a study looking at whether we could predict FDG brain PET from MRI sequences alone. And here's an example. These are 2 patients, one on the top, one on the bottom. The 3 sequences we were looking at were post-contrast scans, flare scans, and arterial spin label blood flow scans. And this is the true FDG PET scan that was obtained at the same time. And this is what the images look like when you predict them with deep learning. And as you can see, they look quite similar, and they also contain the salient imaging findings, which in the top is a cold lesion representing a lack of viable tumor, and on the bottom, a recurrent tumor. So we're very excited about this. Some other groups have been trying to take this further into other areas and other radio tracers. And just given the amount of wealth of information available in modern MRI, I think it'll be very interesting to see if and where this technique has value. Okay, let's switch gears now and talk a little bit about post-processing and quantitation. So the first topic I want to talk about is image co-registration. So this is really crucial for many of the tasks we do in radiology. So if we want to do longitudinal analysis and follow up scans over time, this is very helpful if the images are co-registered. It's also really important for any kind of dynamic scanning where you perturb the system and you expect the person to stay in the same location. So it's very useful for things like motion correction. And anyone who has used the existing methods for co-registration that exist will tell you that they are laborious and they're quite time consuming, and then often inexplicably prone to failure. So I think this is one of the very nice uses of deep learning for post-processing, is to actually develop a fast and accurate way of co-registering images across different time points. Another post-processing application that is tremendously important is segmentation. This is critical for many tasks, and again, is important for longitudinal analysis of lesions. I would say about 50% of my job as a clinical radiologist is just telling people whether things are getting better or worse. And to do that, right now we're using very crude methods, which is me looking at a computer screen and trying to look at the two sides and trying to decide what has changed over time. But I think the ability to actually perform accurate segmentation of lesions in an autonomous fashion will really make this much more accurate than I could ever be. And this is just an example from the BRATS brain tumor challenge, which is a large open access data set showing some examples of ground truth segmentations and then some of the over segmentation that's actually being performed by the algorithm in this case. So I think that we're going to see a lot of these things come into practice very soon, hopefully being integrated directly with PACS. So what are some considerations for AI post-processing apps? One important thing to realize is that they have to be robust to scanner type, to technical errors, or to technologist errors, and to motion. And these are things that really don't happen often in the research setting where you have very compliant, healthy people. So that's certainly something to consider. They need to be tightly integrated into PACS if people are expected to use it, because if we need to move to a separate workstation to process cases, that will really impede adoption. And then the last question really is sort of more philosophical, and that's, how will these come to us? How will they be commercialized? Because a lot of these revolve around the question of, are they companies or are they products? Right now, there are a lot of companies providing AI. There are a lot of FDA approvals. And radiology IT departments really don't want to handle 1,000 different little company and applications. So there is arising this interest in marketplaces or platforms where one can set up AI algorithms in one spot and then pick from them, kind of like you would pick from the Apple iTunes store or something like that. Okay, let's talk next about what is probably the most commonly thought advance for AI, which is interpretation. So the kind of deep networks that we use for interpretation are quite similar to the ones that we use for image transformation. And instead, you can think of them as trying to predict much lower dimensional images. So in this case, this is maybe an algorithm where you would take multiple scans, and then your goal is to classify the scan into one of these 4 conditions. And if you know what the true answer is, you can make a cost function and use that to update the weights of this convolutional neural network. And then, of course, once you're done, you can take a new image, feed it through the network, get a prediction, and hopefully that is of value to the radiologist. Okay, so what does this look like in real life? This is just an example from Stanford, looking at a very large data set from the NIH of frontal chest x-rays, 112,000. And what the goal of this project was to try to identify the presence of these 14 different entities based on a gold standard that was mined from the clinical reports. And the performance metric that is being shown here is the area under the curve, which is a number that goes from 0 to 1, with 1 being higher performance. And the point of this slide is just showing the superior performance of the deep learning network that was described, although it has already been surpassed by other groups. As well as pointing out the fact that having a automated method, which they call ChecksNet, actually tends to agree with radiologists more than they tend to agree with themselves. So this, again, would perhaps be a more desirable thing, although it raises lots of questions about what really is the ground truth. So this has led to people tweeting out things like, should radiologists be worried about losing their jobs? I think this has been less of an issue now as we realize some of the limitations of AI. But again, this has really, I think, caught the public opinion. And that's the one thing I hear from from friends is about how worried I should be as a radiologist from these algorithms. Now, there are other ways to use AI to interpret brain MR, and I just want to highlight this very interesting study from Rauschecker and Rudy that was published in Radiology earlier this year. And their task that they set out was to diagnose these 19 different brain diseases that show abnormalities on one specific sequence called FLAIR. And what they did was something not like I showed you before, but what they did was use deep learning to identify and to segment lesions using the multiple sequences they had available, but then do quantitative measurements within these ROIs and then combine them using a Bayesian network, which would increase or decrease the probabilities of specific diseases based on the findings that were driven by the deep learning identified regions. And then they would essentially rank order the diagnoses and provide a top 1, a top 2, and a top 3 diagnosis. And one of the nice things about this approach is that it's very similar to how radiologists actually do their job. You know, the first thing is they try to find the lesion. The second thing is they try to measure what the signal is within the lesion. They care a lot about the location of the lesion. But, you know, one thing that, you know, the chest X-ray algorithm, for example, couldn't handle was something like input of clinical data. And we all know how important clinical data is to interpreting radiological examinations. So by combining all of these, you know, using a Bayesian type framework, they were actually able to show that the true diagnosis was in one of their top 3 diagnoses almost 90% of the time. And actually this performance was, you know, perhaps even a little bit better than academic neuroradiologists. And I think this is very impressive work. And I think the other thing to take away from this is that this was done in a much smaller number of patients. So this is done in 178 patients. And you'd ask, you know, why did that other study need 112,000 cases? Well, in this case, we're injecting a lot of domain knowledge into the problem. And I think this is really how radiologists can work together with, you know, AI scientists to try to you know, have the best of both worlds and deal with the fact that often we don't have 112,000 cases and we need to do this work in much smaller numbers of patients. So things are moving along, although slowly. I would say this is a really great paper that came out just maybe a couple weeks ago, where a group in Sweden evaluated 3 commercially available AI algorithms to screen mammograms in about 6,000 women. And this is the AUC curve over here on the right. And I'll just focus in on this zoomed in portion here. These lines are the 3 algorithms that they actually evaluated. And then this hatched line here, this point here is where the radiologists basically were operating. So very interesting to see that one of the algorithms seemed to perform better in this setting than any of the radiologists involved. And just to kind of take a look at that, you know, here were the radiologist sensitivity and specificities for identifying breast cancer. You could see the common problem in mammography, which is that the sensitivity is nowhere near as high as the specificity. Now, AI1 in this case, if you ran it at the same specificity level as the radiologists, actually had a little bit better sensitivity. So really, you know, quite similar, but what was really interesting was if they combined the read of the AI and the radiologist together, they could improve the sensitivity quite significantly while still maintaining reasonable specificity. So I think this is very exciting. And while they didn't name the individual companies in this study, if you do a little bit of detective work, you can probably figure out which ones are which. So, you know, once we have information like this, we can start to take this to the next level. It's like, how will we use this AI in practice? Well, this is a very provocative paper that was followed up on that and raised the question is, you know, could we eliminate radiologists in the setting of low scoring AI cases? And then we could use those resources to double read additional cases. And then the other thought that they proposed was that if after this double reading, the case still had a very high likelihood of malignancy based on AI, they should work it up anyway. And what they showed in this was that if you just eliminated the 60% of the lowest scoring cases using the algorithm, you missed 0% of cancers, and this was in 7,000 women. You could see if you raise that threshold a little bit, you start to miss cancers, but at surprisingly low rates. The other thing, which was quite interesting, was this AI rule-in. You know, if you took the 5% highest of the cases that the algorithm found as the highest level, which were called negative by radiologists, they found an additional 27% of interval cancers for the next screening, which are probably the most malignant cancers, as well as 35% of those found on subsequent screening. So very exciting potential here to really use this in a very intelligent fashion. So, you know, is this going to come to your drive-in soon? Probably not so fast. This was an article that was written, or a letter that was written to the FDA from the ACR and the RSNA, saying that they were very worried about this idea of autonomous AI for prime time. And you can read the quote, but basically they thought that the level of safety needed was a long way off, and that autonomously functioning AI should not be implemented at this time. So it will be very interesting to see how this changes moving forward. I think this is a great potential application, but obviously this is obviously going to take a little bit longer than, you know, I guess some of the initial pundits thought. One area that I don't think gets much attention is the idea of using AI not for diagnosis, specifically that's used for immediate diagnosis, but is important for prognostic value. So this is just an example. You know, we all see many scans, and there are many incidental findings that we don't really comment on often. And perhaps we could have AI running in the background to identify some of these things. So this is an example of vertebral body fractures. And we know that if you have a vertebral body fracture, you're at high risk of future fractures. You can run this in the background and then perhaps use this to refer to the primary care physicians for future risk mitigation. It might also be useful for identifying how sick your population is. So in an era where we're increasingly being paid a certain amount of money to insure or care for a certain population, it's very important to understand how high risk your population and how much need they're going to have for medical care. And for example, if you could identify and show that the patients you treat on average have higher coronary calcium scores or have more white matter hyperintensities in the brain, perhaps you could argue with the payers that you might need more money to effectively take care of that patient population. Okay, so I want to finish up by talking about some new and different applications. And I don't have time to talk about scanner harmonization. I'm happy to talk about that in the Q&A if you guys are interested. But let's talk about these two other ones. Okay, so the first I want to talk about is enhancing safety. And we talked a little bit about that when we talked about radiation dose reduction. But in another area where we could perhaps provide some benefit is in the area of MR contrast. So as you know, MR contrast is essential to many studies, particularly about a third of cases get MRI contrast. Now, some patients are unable to get this contrast due to the risk of nephrogenic systemic fibrosis. It's not a small number. And there's also an increasing awareness of gadolinium deposition in the brain and body. And this is just an example here on the right of deposition on an unenhanced T1 weighted image within the dentate nucleus of the cerebellum. And of course, you all know that whether these are dangerous or not is certainly an open question, but there are a lot of patient concerns in this area. So some of the work that we started at Stanford, but now is going on more at Subtle Medical, is this idea of taking low-dose gadolinium images and essentially recreating or predicting what a standard dose image would look like. So here is a full dose image on the left. Here is a 10% dose image on the right, where this lesion, this is a meningioma, is very difficult to see. But you can see if you enhance this using an algorithm that has trained on many, many cases, that this becomes quite evident. So very excited about this application. But when I talk about it, sometimes I feel like this person. I feel like we're doing something pretty remarkable, which is reducing the contrast dose in patients by 90%. But then you have people like this in the audience that look at this and they're just not impressed. Like, I don't want to hear about this application until you can actually do zero dose. And the question is, you know, can you do zero dose? Well, This is one study that's come out of Germany suggesting that perhaps that's possible by taking all of the pre-contrast MRI images and trying to predict what the contrast would look like by training on true contrast-enhanced scans. So I'll run that for you again. On the left here is the true gadolinium uptake. On the right is the predicted by the lesion. And they had some success with this. I would say we've tried this at our institution and we do okay. We often can get very realistic contrast uptake, but it doesn't really work very well for all cases. So I think this is an area of very active research. Okay, so the last topic I want to talk about is predicting the future. So when you think about all the applications I showed you before, the goal was to take an image and predict an image that occurred either simultaneously or very close in time with the assumption that nothing has changed between the scan. It's very straightforward to imagine that you could change the image that you wanted to predict by just swapping in an image that occurs in the future. And if you did that, it becomes very powerful because, you know, if you are successful, you might be able to get an idea of what someone is going to look like in the future, which is really one of the major goals of medicine and radiology. So I want to show you a couple of examples. The first example is to predict cerebrovascular reserve. What is cerebrovascular reserve? It is the cerebral blood flow response to a vasodilatory challenge. So if I give you acetazolamide or I have you hold your breath, I can have you increase your blood flow in the brain if you're normal. Now, if you already are maximally vasodilated, you can't do that. So this is kind of like the idea of a brain stress test. And we know from previous literature that poor reactivity is associated with increased stroke risk. So this project was taken on by a visiting researcher, David Chen from Taiwan, who joined our group. And his thought was that, you know, since we were doing a lot of these cerebrovascular reserve experiments with simultaneous PET MRI anyway, you know, let's see if we can, you know, take the baseline imaging, both perfusion and structural imaging, and then let's just replace the output image we're trying to predict, not by a CBF map, but a change in CBF map between the pre and post drug image. So remember, everything on the left here is before we give the drug, and this image is created from the images before and after the drug. And just like mentioning before, as you would expect, we applied a convolutional neural network to this problem. And here are some of the examples. We actually studied Moyamoya disease patients. These are young patients that have narrowing of their internal carotid arteries and often have very poor reserve. And at the top, these are 12 of our worst cases. And at the top is their true change in blood flow after I give acetazolamide. And here in the second row are the images that we predict based on a deep learning trained model. And you can see the images are not quite the same. But it turns out that if you use these images to try to predict regions of abnormal reactivity, you actually do remarkably well. And in fact, you do better than if you did used our current gold standard that doesn't use PET, which is ASL blood flow imaging, which is shown here, which is very noisy, mainly because this is a subtraction technique. And then you have to subtract pre and post drug images. So you have very noisy images. So you're already performing at better than our clinical standard. So very excited about this work to allow you now to potentially predict augmentation in patients that just undergo routine MRI in which you don't have the bandwidth to perform a drug stress test or to monitor those patients or even, you know, to question whether they can receive the drug at all. So the last topic of predicting the future I want to talk about is stroke. And this is predicting a little bit further in the future. So often when people come in with acute ischemic stroke, we're very interested in how they're going to look in the future, say 2 to 7 days after their stroke when things have settled down. So again, if we have these images, we can look into taking baseline images here as the input to our model, and then a ground truth prediction map of the dead tissue during the first week. And here we've predicted an image that's a very special image. This isn't an image, an anatomic image, but it's an image representing the probability that a voxel will be inside of the lesion of the dead tissue. And you can see in this case, if we use a cutoff of 0.5, that it predicts the lesion quite well. And in fact, currently outperforms the current methods that we use based on diffusion-perfusion mismatches, even though it doesn't understand anything about the physiology. Now, the exciting thing about this is that you can think about now training models for different treatments, right? What I showed you before was just for all comers. Say we were to train a model in patients that were treated for stroke, and one of the treatments for stroke is to give a thrombolytic drug called TPA. And then when we have a new patient that comes in the door, we can apply each of these models to the patient and try to see what their lesion would look like. And so this is an example from some of our colleagues in Denmark. And what they showed was that, for example, in these two patients, very similar, about the same age, about the same severity of stroke, about the same time out. In the top case, the model that is trained in people who receive treatment showed a much smaller lesion than in the model without treatment, suggesting that this patient might be a good patient to treat. Whereas below here, you could see when you ran it through each of these models, it pretty much predicted the same lesion. Again, thinking that maybe this would be a patient that doesn't need to receive the drug, doesn't need to be exposed to any of the risks of thrombolytics. So we're very excited about these techniques to be able to evaluate response to treatment at an individual level. And I would just say that this is not limited to stroke. Stroke's very nice as a proving ground because the changes happen very quickly. But you can imagine any type of trial where you have two different treatment arms. Could you in advance select those who are most likely to respond to treatment? So I just want to talk about a few ongoing challenges. The first, I think, is the lack of large publicly available data sets, particularly tomographic imaging data sets. As I mentioned, this is a bigger issue for classification than for image prediction, but more would certainly be better. Another important thing we're learning is the danger of bias in AI algorithms. That means that, if you train a model in a certain population and then you go and apply it to a different population, and that population may differ based on disease prevalence, it may differ based on the kind of scanner you have, lots of potential for bias. It tends not to perform as well. And so we're very interested in ways of identifying this bias as well as ways of mitigating it using methods such as transfer learning. And then lastly, really, is the high cost of validating the quality of these algorithms. There are a lot of edge cases out there, and everyone has an example of a case that they're particularly proud of identifying because it's so rare. How do we actually make sure that these algorithms work in all of those cases just as well? Multi-reader studies with radiologists are really the gold standard, but very difficult to construct a study that really captures all the things that you need to do. And additionally, these tend to be very expensive studies as well. So I hope I've convinced you that we're in the middle of a new revolution. But revolutions are very messy things. I let you read the quote here. And you're going to see a lot of crazy things being proposed in the literature, a lot of applications that don't make any sense, certainly things that radiologists are much better at and don't need help with. But I think that it will be a very interesting process because there will also be some things that will really transform what we do. And I think our goal is to be one of these people here a little bit in the background, not necessarily these early adopters shown here in the front. So my take-home messages are as follows. I think AI is going to let us do things in radiology either better than we could before, or let us do things that we never could do before. And I think that's exciting. I believe that image quality improvements and cross-modality synthesis may be early movers in this space because there is a lot of hidden information in multimodal imaging. And as humans, our visual system doesn't always detect it. I believe it's also an opportunity to change our assumptions about the trade-offs between image quality, image speed, dose, and safety. I believe co-registration and segmentation will kind of ease into our workflow. We won't perhaps notice that we're using AI, but it will just work better over time. I think that there are a lot of challenges to interpretation apps, but there's certainly progress being made. And if you talk about a long-term process, this is going to be very important. And finally, I think this idea of using AI to predict the future is going to enable us to do personalized radiology. So with that, I want to thank my colleagues for all of their help. I want to thank you for your attention. And I just want to remind everyone on November 3rd to go out and vote. So thank you very much.
Wow. Thank you so much, Greg. That was really a great talk, and I enjoyed it very much. And somehow I was wondering in the middle of your talk if I had voted yet or not. Anyway, so we do have some questions in the chat that I'm going to pose to you. The first one is from Dr. Dennis Parker. He says, Greg, outstanding talk. His question is, the development of AI algorithms depends on the quality and size of the databases. Do you have experience with setting up or using long-term databases? And how can we justify keeping data for the longest time possible before it needs to be destroyed to satisfy IRB requirements?
That's a great question. I'll kind of try to break that down. The first comment I just want to make is about quality versus quantity. And one of the things that has been shown repeatedly with AI studies is that quantity is more important than quality. It's very disturbing to many of us because, obviously we're radiologists. We like to be very meticulous. We always like to get the right diagnosis. It turns out that deep learning algorithms can actually deal with errors in the training set surprisingly well, as long as they're not biased in one way or the other. So that's one thing, and that's why some of these extremely large data sets can be put together using imperfect gold standards, such as reading reports and applying natural language processing to them. Now, I will say it's very important to have a very well curated, high quality data set for your testing set, because you really don't want to be penalized for getting something right in the test set. So that would be the first thing I would say. So large quantities, not so great quality is probably the way to go. Have I tried to set up large databases myself? I would say I have not. I have relied on other people to do this, but I think that it's something that all of us should really start to think about, how we can do this, because it's really a gift for the future. I just point to something like the ADNI project for Alzheimer's disease, where 10 years ago, nobody was going to use deep learning for any of this. And now, because people were able to come together and share data and keep it around, this is really going to enable the ability to identify people at high risk of Alzheimer's disease with techniques that were never envisioned at the beginning time. So it's very challenging. And to your answer about how long can you keep the data around until the IRB complains? I don't know about your IRB, but they do ask us that question. And I always just write 2099. And so far, they've never come back to me and complained. So I think 100 years might be reasonable.
Great answer. So, so our next question is from Dr. Allison Payne, and she says, thank you for your excellent talk. It seems the barriers for AI to enter clinical practice are quite large. How do you envision that AI techniques will initially enter mainstream radiology?
That's a great question. I feel like in medicine in general, we're a very conservative field. And I think that is appropriate to some extent, because, we don't want to bring in stuff that is potentially dangerous. So the real question will be what is the level at which you want to go through the work of buying this, installing it, learning how to use it, making sure over time that it continues to work the way you want to. It's not a simple thing. And right now, I would say that we're seeing this enter kind of in very piecemeal fashions, usually from very forward-looking academic sites, or perhaps even some of our private practice colleagues who are increasingly overworked, who are very interested in this. I think large studies like the one I showed you on breast cancer imaging are going to be essential to make people feel comfortable about this. I think there's going to be a long time before the training wheels are off, in terms of having radiologists look at images at the same time as having AI perhaps add some additional value. But at some point, I believe that the benefits of using this are so going to outweigh the reservations that exist. I mean, you can think about this as MRI when it first came to be used. the proof in the pudding was that it was useful for patients, right? I mean, there was no ground truth for MRI, right? We didn't cut up, tens of thousands of people to see if their brain really looked like the way it did on MRI. Eventually, by using it enough, people became comfortable that the results were meaningful and that they helped take care of patients. So I think that's the real key to think about when you think of an AI algorithm, not so much, how cool it is or what it can do, but, will this help me take care of patients? Will it allow me to do it in a cost-effective way? Am I confident that the company that you're dealing with also, is, looking at the right checks and balances to make sure that patients are protected and that, that they're going to be around for a while so that they can be there when you have a question later on down the line.
Great. Okay, so our next question is from Dr. Ed DeBella. He says, inspiring talk. His question, especially for reconstruction alone, what are the tricks on how to evaluate these networks diagnostically, possibly before multi-reader studies?
Sure, Ed, that's a good question. Well, what we've done typically is look at quantitative metrics as much as possible. So if you acquire a ground truth, higher quality, very slowly acquired image, for example, in the ASL study I showed you, we actually did ASL studies in patients where each study took 30 minutes. So that is a very high SNR image, a very confident ground truth. And we'd look at quantitative metrics such as, the fidelity, the root mean squared error, for example, at every pixel. And I think that that is a good way to start. It definitely doesn't answer all the questions, but at least it does help you maybe judge between two different algorithms and say maybe which one is better or which one you want to continue working on. Frankly, the other way of looking at them is to use them as input into quantitative imaging processing pipelines that you trust. For example, if you are interested in things like MS lesions, there's software that exists that lets you take an image and do a segmentation on that image. And one of the things that we've tried to show in some of our work is that if you take a rapidly acquired low resolution image and then apply a super resolution technique to that, how well does that look like the actual segmentation that you get from the image that was taken with a longer period of time? So there are a couple of tricks, but at some level, as imperfect a gold standard as radiologists are, I feel like that's really important. And, multi-center studies, preferably retest so that we know, how accurate are radiologists themselves when they get the gold standard. It's, not, probably among this crowd, everyone knows that radiologists don't always agree with themselves. 6 months from now, I'll pull up a report from 6 months ago and look at it and say, I said that, but I think that when they're starting to perform at levels that are better than my retest, I think that's the time when we start to think about whether they make sense to deploy more widely.
Okay, that's a great answer. I totally agree. So the next question is from Dr. Minashima, and he says, wonderful presentation, Greg. One question, AI has many strengths and traditional model-based analytical solutions have many strengths. What do you think would be the most efficacious applications in AI in imaging now and in the future, or will it be only AI in the future?
That's a great question. I think that when we have a physical model, for example, in something like PET reconstruction or MR reconstruction, it is likely that combining AI together with that understanding of the world will allow us to do better. It may allow us to do better in the sense of maybe training on less examples, maybe being able to handle edge cases better. So I don't think there's any reason not to use it. But I think that as we get to larger and larger numbers in our trials, the question will be that, physical models are wonderful, but as we all know, we still get artifacts in our images using these physical models. So, in the long run, to me, it's going to come down to what kind of algorithms are going to produce images, in a cost-effective way, in a radiation safety effective way, and in a patient care way, you know, and how we actually go from the sensor data to the imaging data, is probably a detail that most of us don't care about anyway when we're reading images. But obviously people who are working in this and are facile in both areas are going to be at a great advantage, especially in the small data domain. But in answer to your question, I don't know how this is all going to play out, but it's a very exciting time.
Yep, it certainly is. I was just told we have time for 2 more questions. So one question from June Taylor is there a problem? There is a problem with tomographic databases. They can be used to reconstruct faces, and consequently places like the Mayo Clinic won't put their images in public databases. Can you suggest a solution to this?
Yeah, that's a great question. And I feel like I almost would have planted that question in the audience for someone to ask me that question, because I have very strong opinions about that. And my opinion is that, a lot of what you learn in neuroradiology is that the face predicts the brain in many ways. And I think there's a lot of information in the face that's probably useful for these algorithms. There are techniques that allow you to remove the face from images such that they can't be identified, called defacing. My sense is that, the idea of re-identification is a very theoretical one. And in fact, I would argue that no one has ever been identified from the general public from an high resolution imaging exam. Now, it's not to say that techniques might get better over time, but in fact, there's a challenge out there if you want that I can point you to where, someone is offering a nice case of champagne to anyone who can identify the brain that he has put up online. So I think you have to balance risk versus reward, right? Because, the risk is theoretical. I think if you have a very small patient population, like a group of 80 people, and you all know who is who, you can say that you can predict who is who with better frequency. But if I have an image and it could be one of every 8 billion people on the face of the earth, I think that's a bit harder task. And I'm not sure that that's going to be cracked anytime soon. So I feel like the value for patient care from databases like ADNI, which have not done defacing, has been so immense that if defacing was required, it would then require anyone who wanted to use the algorithms that were developed to deface in exactly the same way they did. And you don't really know how that would influence the algorithms. So I feel like, medical research is all about risk and reward. And to me, the real risk that we have right now is not sharing data. And I think we can all come up with reasons why it might be dangerous. And I think it's reasonable to take, simple safeguards. But I think when we start talking about theoretical risks, it kind of drives me crazy, because I feel like there are people that are going to benefit from this that are missing out because, we're so concerned about privacy.
Yeah, I couldn't agree more. So we have time for just one final question before we move on to our next part of the afternoon. And this one is from Dr. Yoshini Anzai, who says, thanks, Greg, fantastic talk. I think improving image quality or speed or reducing dose is going to happen or is already happening. For diagnosis or detection of disease, it's a bit controversial due to liability. Another challenge is payment. Who are the consumers of the AI algorithms? Are they radiologists or hospitals or payers?
That's a good question. Yeah, one of the challenges with these algorithms is, how can you always be sure that you're going to get the same diagnosis that you would have gotten if you took longer? And there's almost no way to answer that in all possible cases. But I would argue a couple things. Number one is that if I imaged you twice as long, I would also see more stuff. But we don't do it. And we don't talk about the liability of not imaging people twice as long as we do now. I mean, it's well known that if you double dose gadolinium, for example, you'll see more metastases. Does that mean that you have liability if you're only using single dose? I don't think so. So it really comes down to a trade-off and also an accessibility issue, right? If there are people that aren't getting scanned because we don't have time on our scanners, or because people can't afford them, especially in rural areas or underserved populations, you know, it's probably better to be doing those scans than not to be doing them. That's kind of my feeling. And then in terms of who pays for them, you know, that's a great question. I think that a lot of practices that see the opportunity to enhance the throughput of their scanner are willing to pay for that, because you've essentially, you can imagine that, you know, now you have one scanner and you have a fixed cost and you can scan, you know, 50% more patients. That's, you know, 50%, you know, you don't have to buy another scanner to do that. And you will obviously get reimbursed for that. So, you know, in a lot of settings, it is the practice organizers or the departments. I haven't had too many conversations with payers about this, but you know, there's always pressure on reducing the reimbursement for MRI. And I feel like, you know, this is one way we can kind of defend against that to some extent. So that's the best I have, Rashini.
So we're going to move on to the next part, but I wanted to encourage you, there are still some questions in the Q&A part, and you can answer those. You can type those directly in and answer them yourself. So hopefully you can do that while we're listening to the next group of speakers. So thank you very much again. That was really a great talk, and I was just blown away by the comprehensive nature of everything you presented. That was great. Thank you. So I'm pleased to invite today's panel of emerging investigators to give their talks. At the end of these talks, we will be awarding the prize for top emerging investigator for this year's Imaging Elevated, which includes the investigators who presented on Wednesday. So we'll wait with the Q&A until all the investigators have given their talks, and please remember again to use the Q&A button, not the chat function. So the first speaker today will be Christopher Paccia, a graduate student from Washington University, St. Louis.
Hello, everyone. My name is Christopher Paccia, and I'm a fourth-year PhD student at Washington University in St. Louis. I'm going to talk with you about focused ultrasound, which is a field that was first introduced to me 3 years ago, but will continue to keep me interested with its endless possibilities and medical applications. So I want to thank the University of Utah for the invitation to present my work on the feasibility and safety of focused ultrasound-enabled liquid biopsy. Ultrasound has canonically been known as an imaging tool that has recently become more accessible and reliable. This has given doctors the ability to diagnose diseases with only a phone or tablet and a portable ultrasound probe. So all it takes are sound waves to unlock the mystery of human diseases. We are developing another ultrasound tool that utilizes focused ultrasound and will enable doctors to understand brain diseases at a level that is not currently possible with MRI or surgical biopsy. So my goal today is to convince you that focused ultrasound, or FUS, will be a pivotal tool for fighting brain cancer. Similar to a magnifying glass that focuses light onto a single location, the FUS device concentrates sound waves onto a spot the size of a grain of rice. Unlike light, these sound waves can penetrate through the skull and brain tissue, so no surgery is needed for this procedure. The added benefit of no ionizing radiation, deep penetration, and high spatial precision make this modality unlike any current medical tool. My work focuses on the use of FUS to overcome the blood-brain barrier, or BBB. The BBB is a structural barrier between the blood vessels and brain tissue, and has the important task of regulating the transport of molecules across this interface. While this is beneficial for ensuring homeostasis in the brain and protecting neural tissue from foreign pathogens, this restricted permeability ultimately hinders the transport of tumor-specific DNA and RNA and chemotherapeutic drugs. We aim to change that by disrupting the BBB with FUS and locally enhancing the permeability. The goal for FUS liquid biopsy is to replace the surgical needle with a non-invasive FUS transducer. FUS with microbubbles is known to be a safe, non-invasive, spatially targeted technique to reversibly disrupt the BBB for brain drug delivery. In past studies, we've demonstrated that FUS-induced BBB disruption opens a two-way trafficking between the brain and blood, thus enhancing the release of brain tumor biomarkers into the bloodstream. After FUS sonication, a simple blood draw can now provide information on the molecular profile of the brain tumor to enable precision medicine. So the objective for my work is to demonstrate the feasibility to diagnose glioblastoma from different biomarker types and species. We selected glioblastoma, or GBM, because it is the most common primary brain tumor, with less than 5% of patients surviving 5 years after diagnosis. We analyzed the release of messenger RNA, or mRNA, in the mouse GBM model, because mRNA has been used in the clinic to monitor therapy response and identify genetic mutations. We quantified the release of circulating tumor DNA, or ctDNA, in the rat GBM model, because ctDNA is the most common circulating biomarker analyzed in the clinic, and it is derived from tumor cells, so it directly relates to tumor burden, progression, and therapy response. Lastly, we analyzed 2 brain-specific proteins in a non-tumor pig model to demonstrate the feasibility of FUS liquid biopsy in a large animal. In the mouse GBM model, we observed a significant increase in mRNA levels when the blood was collected 10 minutes post-FUS. Additionally, with different FUS pressures, or the amount of ultrasound energy delivered, we observed significantly greater mRNA levels in the blood for pressures above 1 megapascal. And with different microbubble doses, we observed significantly greater blood mRNA levels for the doses that were 5 times the clinical dose or higher. These results suggest that careful optimization of FUS parameters will improve the detection of mRNA. The rats were split into either a sham or a FUS-treated group, and the subjects were further grouped by their tumor size, which corresponds to the early or late-stage cancers. Our results show that FUS enhanced the ctDNA release from small tumors by more than 2-fold compared to the sham group, and nearly 4-fold if the tumor was large. This suggests not only that FUS enhances the release of ctDNA into the blood circulation, but also that the tumor size may have an important role in enhancing the release of ctDNA. To establish the feasibility of FUS liquid biopsy in large animals, we started with non-tumor pig subjects and selected 2 brain-specific biomarkers as a proof of concept: glial fibrillary acidic protein, or GFAP, and myelin basic protein, or MBP. GFAP is the major component for the intermediate filaments that make up the astrocyte cytoskeleton and has been previously used as a brain-specific biomarker because it correlates well with high-grade glioma volume. On the other hand, MBP is a commonly used marker for demyelination in the central nervous system for patients with multiple sclerosis. We found there is a significant increase in both GFAP and MBP concentration in the blood post-FUS compared with pre-FUS, suggesting that FUS liquid biopsy does enhance the release of brain-specific proteins in the large animal model. So through our work, we've demonstrated that FUS liquid biopsy provides valuable molecular information without the need for surgery in order to non-invasively diagnose brain diseases. One of the numerous applications for FUS liquid biopsy is the diagnosis of tumors in surgically inoperable locations or for high-risk patients where surgery is just too dangerous. In addition, FUS liquid biopsy can be used to detect early-stage brain cancer or monitor tumor progression and treatment response. So I hope that I've convinced you that the fight against brain cancer just got a little bit easier with the advent of FUS liquid biopsy. And I'd like to thank everyone in the Chen Lab for the help and support, as well as the funding agencies that have made this work possible. Thank you, and I'll be happy to take any questions.
Okay, that was very excellent. Thank you, Christopher. So I just want to remind everyone you can put the questions in the Q&A now in the box, and then we will answer them at the end of all the investigators. But go ahead and enter your questions in at any time. Thank you. So our next speaker will be Dr. Kevin Chen, a postdoc from Stanford.
Hi, my name is Kevin Chen. I am from Stanford, and I work with Dr. Greg Zacharczyk in my postdoc studies. And today I would like to share with all of you my project, which is entitled Deep Learning Enhancement of Ultra-Low Injected Dose Amyloid PET MRI. The reason we're concerned with dose reduction is First of all, a standard FDG, which is a glucose analog, PET-CT scan gives a radiation dose of around 6 to 32 millisieverts, and that adds a cancer risk per study. Now, with PET MRI machines, we can eliminate the CT component, or more than half of the radiation dose. But our question is, can we reduce PET radiation further with deep learning? So here we can see as we go from a standard dose to a very low dose, such as 200 times lower than the original, we can go from something like the equivalent of 3 non-contrast head CTs all the way to a transcontinental plane flight. However, there is a trade-off between dose reduction and image quality, as you can see in the previous slide. So here, the approach we're taking is to denoise the low-dose images through this deep learning model, or a CNN, and we also combine MR information along with it. And here, we choose to demonstrate this application through amyloid PET imaging, and the reason is threefold. First of all, amyloid plaque buildup precedes the presentation of dementia and is an important biomarker for Alzheimer's disease diagnosis. Second of all, when clinicians read the images, we can see that AD patients usually show tracer retention in the cerebral cortex, and that's called positive. So this dichotomy of positive versus negative will help us in doing subsequent analyses. Also, there is potential. So currently, there are clinical trials for amyloid-clearing drugs, and we think that with a need for more frequent PET scanning, then hopefully they can incorporate our deep learning-based approach into this study. And so with simulated data, what we have done is we recruited 40 subjects for scanning, and we injected this amyloid tracer florbetaben. So we can see that with our simulations going from the low dose image, which is the rightmost column in the bottom right picture, you can see the large amount of image noise is reduced as we pass this image through the deep learning network. And we can see that adding MR information helps as well. So in the middle column, we can see that what is generated from our network, the uptake pattern really follows the gyri and sulci of the brain, and it is quite comparable to the full dose PET image. And what we are doing now is actually injecting a very low dose into the patient. So here is our sample protocol. So for each participant, we recruit them and we scan them twice, basically. The first scan is a very low dose injection into the body. So you can see here it is about 2% of the original dose. And so here we scan the PET MR simultaneously. We get a set of images, and then we scan them again with the standard dose. So then we have 2 sets of PET and MR images that we can put into the neural network for training and testing. And here are the results of the images. So first of all, we can again see that there is markedly reduced noise comparing the raw ultra-low dose images to the CNN-enhanced PET images. And comparing the enhanced images to the full dose images, we can also see that the uptake pattern between the two sets of images are quite similar. And we also looked at the uptake values within the brain of all of these image types, and we can see that the correlation of the uptake value between these image types are very high, and close to 1 actually. So that shows that the neural network is also outputting quite accurate images. Now, we also have clinicians do expert readings on the images as well. And the first thing that they did is give a subjective image quality score to all the images. And we can see that a majority of the readings for the ultra-low dose images were deemed uninterpretable. So they scored the lowest, or a score of 1 on the 5-point scale. And the readers also preferred the enhanced images more, which scored close to the full dose images. Now, they also read all of the images as positive versus negative, and we can see that the deep learning images generated from the neural network are quite accurate. So when we look at the confusion matrix here on the left, we can see that out of all the readings, only 2 were read differently. Now, that is quite comparable to reading the full dose a second time, where we can see on the right there, the confusion matrix shows that there is 1 reading that is read differently. So the accuracy is quite comparable. And so we showed that the enhanced images have a marked improvement in noise reduction to the ultra-low dose image and resemble the ground truth image. And the mean radio tracer uptake within the brain also highly correlated across image types. So diagnostic amyloid PET images can be generated using this sort of deep learning method and a multimodal approach. And so with that, I would like to thank Dr. Zacharczyk, Dr. Mosley, our lab mates, collaborators, funding sources. And I would also like to thank you for your attention. And I'm also happy to take any questions. Thank you.
Thank you, Kevin. That was a very wonderful talk. And our next speaker will be Dr. Kelly Smart, who is a postdoc from Yale University.
I'm Kelly Smart, currently a postdoc at Yale University. Thanks to the organizers for inviting me to speak today. So I'll be presenting my work on a novel method to measure variation in acetylcholine concentration using PET occupancy studies. So this work was supported by my mentor, Dr. Ansel Hilmer, and along with Rich Carson, and was funded by NIDA, NIMH, NIAAA, and Eli Lilly. So brain signaling emerges from a really staggering combination of different cell types, neurotransmitters, receptors, and so on, that are all interacting with and influencing one another. So with PET imaging, we can visualize specific targets using radioactively labeled probes and measure their binding in the living brain, as in the orange and red PET image on the right. Many different things can influence how a radiotracer binds at the molecular level, but with PET, we reduce a complex system down to a model and assume that a lot of that complexity just washes away. So this is really useful and effective, and we've learned a lot about different diseases this way, but it does mean that we're ignoring a lot of biological reality. So I'm primarily a biologist and a pharmacologist, so the goal of my research is to identify ways that we can bring some of that complexity back into our PET analysis. So I'm going to go through one example of this work that I've recently completed. So this is based on drug occupancy studies. So for a typical receptor PET scan, we inject a radiolabeled drug that binds to the receptor we're interested in, and then quantify the target based on classic ligand-receptor kinetic relationships. So for a blocking scan, we repeat the process, but before giving the tracer, we inject a competitor drug that's not labeled, but binds at the same site. So it blocks our radiotracer from binding, and then we quantify the loss of brightness between the top image and the bottom image, and that gives us receptor occupancy, the percent of all the sites that are occupied by the cold drug. So the bit of complexity that we're trying to add back in these studies is the role of the endogenous transmitter, which also binds at the same site as the drug and the tracer. So the radiotracer is given at a very low dose, so it can't bind at sites that are already occupied by the endogenous transmitter. Those are the blue slice in these diagrams. So if we compare 2 different brain regions, even if they have the same number of total binding sites, if one has a lot more endogenous transmitter, then in a PET scan, we're going to see a lower signal. But we can't actually figure out the size of that blue slice from a single scan because we can't image it. However, when we add a competitor drug that binds at, say, 20% of all sites, including the ones that were previously bound to the endogenous transmitter, that's the green stripe on blue slice here, then occupancy is going to be underestimated. Essentially, we're losing occupancy because it's occurring at sites that we couldn't see in the first place. And this underestimation is larger for regions with a greater amount of endogenous neurotransmitter. So the key thing is that this system follows well-characterized pharmacological relationship, which lets us use the difference in occupancy estimates to quantify the difference in neurotransmitter concentration, the difference in the size of the blue slices here. So we decided to explore this in the acetylcholine system. So there are two main cholinergic systems in the brain. In the cortex, it controls attention and cognition, while in the striatum, in red here, there are local interneurons that release a lot of acetylcholine, which are important in motor control and reward. So from rodent studies, it's been shown that acetylcholine concentration is around 3 or 4 times higher in the striatum compared to the rest of the brain. But the balance between these two systems might be really important. For example, in a disease like addiction, where you're looking at a balance between cognitive control and reward responses, those are two competing cholinergic pathways. So we picked acetylcholine for these studies because we expected to see a specific, robust regional difference in concentration, and because it is clinically important. So we did 3 occupancy studies, 2 using a radiotracer targeting M1 muscarinic receptors with the competitor drug scopolamine, and 1 targeting nicotinic alpha-4 beta-2 receptors with the competitor drug nicotine. So first we looked at M1 receptors in humans. We did baseline and blocking scans and found that when we measured occupancy, it was lower in the striatum in red compared to the rest of the brain in blue in all our subjects. In individual regions, the striatal subregions caudate, putamen, and ventral striatum consistently stood out as having lower occupancy. So even though we were administering this drug systemically, just as a patch, and it should have roughly the same concentration across the whole brain, we were consistently measuring lower occupancy in the striatum compared to any other region. We then repeated this study in monkeys using 2 different doses and found the same pattern of lower occupancy in the striatum compared to the rest of the brain. And then we did another study looking at a different kind of cholinergic receptor and 2 doses of nicotine as a competitor. And again, we see a pattern of lower occupancy in the striatum compared to the rest of the brain. This relationship did start to break down at very high doses of nicotine, but that's actually what we expect from the pharmacological relationships. The gap should start to close when the dose of our competitor drug is getting very high. So we went 1 step further and used these occupancy estimates to quantify the difference in acetylcholine concentration. So we defined this quantity delta A, which is derived from the relationships between our binding measures and the underlying systems, and we calculated it from our occupancy estimates. This ended up telling us that acetylcholine concentration was about 2.5 times higher in the striatum on average in these healthy people. So that's in line with what has been shown using microdialysis in rodents. And of course, there's nothing special about the striatum as far as the math is concerned. So we can also do this at the whole brain level and calculate delta A at each voxel for each person. So we can start to appreciate some finer differences. Higher acetylcholine around the hippocampus in the temporal lobe, and higher concentrations in the frontal cortex compared to the occipital cortex. So we show for the first time that acetylcholine concentrations are higher in the striatum in the living human brain, and we're able to put a number on that difference. These regional differences in acetylcholine concentration could tell us something really important about neuropsychiatric diseases. For example, we might expect that this difference would be higher in Parkinson's disease compared to healthy people, but lower in people with mood disorders. So that means that we've developed a tool that can measure a wholly new aspect of neurochemical function in living people, which could help us understand, diagnose, or track certain illnesses. So we could use this to compare groups of patients with the fairly standard procedures of a PET occupancy study, and we'd be getting information about both the target and the endogenous transmitter or presynaptic processes at the same time. So we think we can use the information that's contained in PET scans that we're already doing to open up a brand new avenue of research. Thanks for your attention.
Thank you, Kelly. That was great work. Our next speaker will be Dr. Xingfen Xiao, who's a postdoc from USC.
Hello, everyone. My name is Xingfen Xiao from University of Southern California. Thanks so much for this opportunity to present here. And today my topic is about blood-brain barrier. And I'm going to talk about our novel, non-invasive technique to measure water exchange rate across the blood-brain barrier. So here's some background. This is a diagram of the blood-brain barrier. As you can see, there are multiple layers between the vascular and the tissue space. So the transendothelial permeability is very low with a functional BBB. However, the BBB permeability increases with advancing aging, especially in patients with vascular dementia or cerebral small vessel disease. So currently, the golden standard to measure the BBB permeability is using dynamic contrast enhanced MRI and with gadolinium-based contrast agents injection. So it has been used to study a very broad spectrum of the CNS disorders which are associated with BBB disruption. However, recently, people are thinking about if the water exchange across the BBB is free diffusion or is there other mechanisms. So people recently discovered there's a water channel called aquaporin 4, those like small green dots. So water actually was more efficiently goes through those aquaporin 4, AQP4. And the more recently studies showing that those AQP4 deficiency affects the lymphatic function. So, so people see that loss of AQP4 happens with aging. And I'm going to show later the amyloid deposits is associated with AQP4 redistribution. So here's a diagram. On top, you see in the healthy brain. So those blue dots are the polarized AQP4. It nicely go along the end feet of the astrocytes. So which means you have an efficient clearance system to carry your blood waste and go to your tissue and eventually like go to vein and go out of your brain. However, in the AD cases, as you can see, there's some redistribution of those black dots, the AQP4, which means your clearance system, get a lower efficiency. As a result, you can see the brain waste accumulates in this perivascular space. So our MR experiments will conduct on the Siemens 3T Prisma scanner. So our technique is called diffusion prepared arterial spin labeling. So as you may know, the ASL technique was originally designed to measure perfusion and a certain post-labeling delay. So our technique added a perfusion preparation at the beginning of the acquisition to separate the vascular and tissue compartments. And we also developed the TGV regularized SPA modeling. So here you can see, based on the ratio of those two maps, we can estimate how fast the specifically labeled blood signal goes from the capillary to the tissue. So we quantify this KW in terms of the water exchange rate, the units is per minute. So our total scan is about 10 minutes. And here I'm going to show you our results from two studies. The first study we want to see is how is our developed KW map correlated to the golden standard DC MRI. So we had 16 age subjects, and we first tested reproducibility of our technique from test retest scans about 6 weeks apart. And the goal is to find a correlation between the KW and the K-trans measurements. And our study is to trying to figure out if the KW has any association between other early biomarkers of AD. So we get 39 older subjects without any neurological disease. And we collect the CSF sample by lumbar puncture and do the quantification of the CSF levels of A-beta 42, tau, and the p-tau values. So those are early biomarkers before the AD actually you can diagnose. So here are the results from the first study. This is a BA plot of the test retest KW measurements. So the difference between the two measurements is very small. And we found a pretty good ICC. It's kind of a measure of the reproducibility in larger brain RIs in the whole brain gray-white matter, the MC perforated territory, and also in caudate. So here's a major finding of our first study. So this is a scatter plot of the K-trans versus KW from test retest scans. And this is a table summarize the regression coefficients and the p-values of those regressions. So as you can see, we found significant correlation in only 3 brain areas, the wet matter, MCA perforated territory, and also caudate. So this is very interesting because we're thinking those are two different mechanisms. It's like one is a leakage to the contrast agents. The other is kind of the water exchange ratio. So there are two different mechanisms. So the correlation we found here may be induced by some vascular function changes induced by the small vessel disease. Is from our unique study population. So here are the results from our second study. So actually our technique can produce CBF, the blood flow, the arterial transit time, and the KW, the water exchange rate, in the 10-minute scan. So from those 3 representative subjects, as you can see, the CSF A-beta 42 level increase, which means you get a more A-beta 42 in your CSF, which indicates a stronger clearance system in your brain and your blood-brain barrier. So accordingly, as you can see here, the KW map increase with increased CSF A-beta 42. So we did statistical analysis in all 39 healthy subjects. We found significant correlation between the CSF A-beta 42 and the KW in several areas like whole brain, the frontal lobe, parietal lobe, temporal lobe, and the precuneus. So it's very interesting. Our KW is promising to be early biomarker of AD, which is non-invasive. So you don't have to do lumbar puncture to get your CSF as a biomarker. So in conclusion, our technique shows good test-retest reproducibility, which is important, especially if you want to do the clinical studies. And we also found significant positive correlations between our KW and gold standard K-trans, but only in the brain regions that are most susceptible to the vascular impairments caused by the cerebral small vessel disease. And lastly, we found our lower CSF A-beta-42 level is associated with decreased KW. So this indicates that altered AQP expression may hamper the clearance of the interstitial A-beta-42 and render the aging brain vulnerable in neurodegenerative conditions. So that's all my presentation today. So I'm gonna like to thank my colleagues from the University of Southern California and also University of Kentucky, Dr. Brian Gold, and Keith from Western University. And also thanks for the NIH grants and also Siemens Healthineers. So let me stop sharing here. And I want to thank you all again for inviting me today. If you're interested in my research, please feel free to contact me. And I have been to the Salt Lake City once. It's a really beautiful city. And I really hope in one day we can all reunion again and talk each other research. And thank you all and stay safe. Bye-bye.
Thank you, Xingfeng. That was an excellent talk. And for our final speaker, we would like to invite Dr. Hemant Agarwal, a postdoc from the University of Iowa.
Hello everyone, this is Hemant from Computational Biomedical Imaging Group of the University of Iowa. So here I am working as a postdoc scholar. Today I will be talking about our work on model-based deep learning architecture and its applications to parallel MRI. Let's get started. So in MRI, when a patient goes into the MRI scanner, we can take all the samples and we then simply take inverse Fourier transform to get the image. However, to speed up the MR image acquisition process, we can take fewer samples. We get this kind of case space. This is undersampled case space. In this case, if we just take inverse Fourier transform, we get an aliased image. So to reconstruct this kind of image, we resort to a reconstruction algorithm. In particular, we use compressed sensing-based approaches where we solve this kind of optimization problem. So here we have a data consistency stack that finds a solution that satisfies the imaging physics and with the help of an image prior. So this exploits the image properties. There are two challenges. One is the reconstruction time is high with the compressed sensing-based approaches, and the reconstruction quality depends on the choice of prior. To alleviate these two issues, we go to a deep learning-based solution where we utilize the convolutional neural network to get a reconstructed image. This is termed as a direct inversion approach. The issue with these approaches are that the reconstructed image is not necessarily data consistent. So we can satisfy the imaging physics by using model-based deep learning architecture. Here we utilize a convolutional neural network only as a regularizer rather than completely relying on it. So we term these approaches as model-based deep learning approaches. In particular, we proposed a model architecture where we start with the aliased image and we utilize the convolutional neural network together with the conjugate gradient based data consistency step, and we iterate it a few times to solve for the optimization problem, and then we get a reconstructed image. So the benefit of the proposed model algorithm was that it can handle arbitrary A operator. So in different applications, we might have a A operator where we may not have analytical inverse, rather we need an optimization subblock. So this architecture helps that. So we showed its applications to parallel MRI. So here A operator includes call sensitivity maps. We can see that at 6-fold acceleration, we get very good reconstruction quality. So we also show its application to multi-shot diffusion MRI. So in multi-shot diffusion MRI, if we just use a single shot, we know that we have a very low SNR. As we increase the number of shots, we can get higher SNR. However, it comes at a cost. So multi-shot API has phase errors. So if we have just two shots, and if we simply combine the two shots, there are different phase errors, and the combined image has is phase corrupted. So to reduce these phase errors, we proposed a model muscles architecture, where we start with the phase corrupted image, and we have a k-space network that exploits the proper phase relations in the k-space together with the image space network. So here we again ensure the data consistency step. So here this time the A operators are different as per the shots. As for each shot we have a different A operator, and we iterate it a few times to get a phase corrected image. So here we can see the results and the comparison to the compass-sensing based approach, which is the muscles approach. It takes 19 minutes, whereas the proposed approach takes just 47 seconds. And with just 3 iterations, so we get a better contrast. So you can see this is a zoomed result, and the contrast improves as compared to 1 iteration model. And you can see the noise also gets reduced here. So we also show its applications to sampling pattern optimization. So we know that the variable density sampling mask provides better reconstruction quality as compared to a random sampling mask. So in the here, as we see from the peak signal to noise ratio, the higher the PSNR, better is the reconstruction quality. Can we get even better reconstruction quality as if we optimize the sampling mask? So this is the question we are solving in this problem. So the goal of this work was to jointly learn both the sampling mask and the network together. So in particular, we propose the continuous optimization of the sampling parameter. So in the image formation model, so theta is the sampling mask, so which we implemented as a one-dimensional non-uniform Fourier transform. So we know that in Fourier transform, the frequency locations are discrete values. However, we let them to be real numbers as in non-uniform Fourier transform, and we make them trainable. So this kind of continuous optimization helps during backpropagation, and this kind of parameterization also reduces the number of trainable parameters. So together with the sampling pattern optimization, we optimize the network as well, and these are the reconstruction quality. So we see that learned sampling mask gives even better reconstruction quality as compared to the variable density. So in all 3 cases, the acceleration factor is the same, but we see that the PSNR value improves. Here we see some more results. So with the joint learning, so this is the ground truth image. This is, if we see just in the cerebellum region, we can see that the fine details are well preserved by the joint learning approach as compared to when we do not optimize the sampling mask. So these are the benefits of this approach. Thank you again for giving me chance to present here our work on symposium. Thank you.
Thank you, Himat. That was a great talk. So now I would like to go on to the question and answer for all the panelists. And first, I'd like to ask if Dr. Zaharchuk has any questions for our presenters today. Great. We can't hear you. You may be muted.
I am. I had a question for Christopher's presentation. I was very intrigued by the idea of disrupting the blood-brain barrier to get mRNA samples. I just wondered if you've given any thought to, obviously the blood-brain barrier is there for a reason. Do you think that doing that could lead to like bad things, other bad things getting out or bad things getting into the brain? I mean, is there a risk of humans? What do you think this would take to really move to humans?
Sorry, we're still working on getting all the panelists into the room together. So 1 second, just be patient.
No problem.
Okay, I think we're ready, at least with Christopher.
Hi, Dr. Zaharchak.
Mhm.
Thank you. Thank you for the great question. So that is definitely one of the concerns, is that, we're temporarily disrupting the blood-brain barrier. So it'll stay open for 24, 48 hours, and that can change depending on our procedure. And so one of the major issues that we need to consider, or in moving into the clinical trial, is how does this impact metastasis? So we can specifically limit the amount of BBB disruption, so then only DNA and RNA pass into the blood vessel instead of the circulating tumor cells that can cause metastasis. But I'd like to point out that this focused ultrasound blood-brain barrier disruption has actually been incorporated and been done in a couple clinical trials already. And so they've already shown the feasibility and safety for opening the blood-brain barrier in Alzheimer's and ALS patients, just to name a few off the top of my head. So it's definitely starting to pick up in applications in the clinic. And I just hope that we can start to use this FUS liquid biopsy technique also in the clinical trial.
Yeah, no, very interesting. I mean, that kind of, when you mentioned Alzheimer's disease, it made me think about Jinfeng's talk. And I just wanted to kind of understand some of the work that's come out of USC has suggested that patients with Alzheimer's disease have increased permeability with age. And when you showed me that picture of the aquaporin molecules, moving around and going away, the implication to me was that that would reduce transport across the blood-brain barrier. So I just wondered if I was understanding that right, or how do you kind of reconcile those things?
Oh, sorry. Can you hear me? Yeah, I think in their study, they show increased BBB permeability in hippocampus. I mean, that's the first step you're starting seeing leakage of the contrast, the gadolinium-based contrast. So that's something happens when your blood-brain barrier already maybe have some disruption, maybe the tight junction disappear, or some other effects affecting your vascular health. But for the water exchange, we're thinking there are two differences. First, the water, the size is much smaller. So that's kind of a common movement of the water go across the blood-brain barrier. And secondly, the water is very special, is go across the blood-brain barrier by a very special mechanism by those aquaporin 4. So we were thinking this may be more sensitive to some specific disease and maybe at an earlier stage of the disease progression. So we're looking at two different mechanisms. So I think there might be some difference.
Yeah, no, I think it's a great question. I mean, you were using DCE kind of as a metric for water in your study, but and one of the things when I saw you doing that was thinking, of course, if we want to predict zero dose gadolinium maps, maybe we should be using this technique. But it sounds like there's sort of different mechanisms.
Yeah, it's still under investigation. We see whether, each one can reproduce another, but I think it may be a little bit challenging because there are two different mechanisms underlying the, yeah.
Mm-hmm. Yeah, that's great. I did have a question for Kelly about the receptor occupancy studies. I thought that was very interesting. I just wondered if you could maybe explain a little bit how, how would you envision this being used clinically? Like how long would the exams be? They would have to come in with and without a blocking agent. Is this something that we could do today? Is this, what do you think are maybe some of the clinical challenges associated with it?
Yeah, thanks for the question and for inviting me to be here. That's a really good consideration. It's probably a little early at this point. I'm mainly thinking of it in terms of clinical research applications, so different things that we can study in trials and things like that, where we can get away with slightly more demanding studies in our participants. But eventually, if this was kind of well validated enough to make it into the clinic, then there are things that we can do to make it more feasible in patients. So depending on your choice of radiotracer and blocking drug, there are ways to get it down. It's, I think, always going to be 2 scans, but we could get it down with the right tracer down to a 30 or 40-minute scan each time. And then safety of the blocking drug, which we would really just be using as a probe, would obviously be key. The good thing in terms of clinical applications is that this, based on our studies so far and based on the math, this should work best with a relatively low dose of the blocking drug. So just under 50% of the EC50 for receptor occupancy is ideal. So we shouldn't be seeing really strong pharmacological effects at that point, but that would obviously be a consideration in clinical practice.
Yeah, I was going to ask you about that, like how pleasant it is to have all of your receptors occupied.
I mean, if it's nicotine, it's not so bad, I guess. But
yes, as long as you don't get addicted to it at some point.
Yeah, exactly.
Yeah, but a 40-minute study times 2 is not unreasonable out there. Certainly, we have a lot of studies where people come back the next day, for example, you know, if it's valuable. And certainly, especially when you talk about psychiatric diseases, when we really don't have any alternatives.
Yeah.
And if we could start to understand and classify those in some meaningful way, you know, I think that's a really big deal. So it's very exciting.
Yeah, it's early, but I think it's pretty promising.
So I'm going to jump in because my timekeeper is reminding me that it would be nice to finish on time, although we may not. We're going to try. But if we could answer some of the chat questions first, and then if we still have some time, Greg can keep going. So we have a couple of questions for Christopher. The first from Zingfen was, is the BBB opening induced by FUS reversible, or are the tight junction proteins damaged?
Yeah, and that is a really good question. And I sort of touched on it before, but this is reversible. We expect the BBB should return within a couple hours to 24 hours. So the type of BBB disruption that we're doing is very safe and very transient compared to other FUS techniques that I won't touch on, but our technique is safe, reliable, robust.
Okay, another question for Christopher from Dr. Payne. Thank you for a great talk. What size of BBB opening do you achieve to get your results? Was it different in the rat mouse model compared to a larger pig model?
Yes, that's a good question, Dr. Payne. So the way that we've opened the blood-brain barrier is specifically, we'll target a single point in the tumor center, and we'll just open the blood-brain barrier within that area. The focal size of our FUS transducer is about 1 millimeter by 1 millimeter by about 5 millimeters, and that's for the mice and the rats. For the pigs, it's a little bit larger because it is a much larger animal, and it's about 3 millimeter by 3 millimeter focal area. So that's the amount of BBB disruption that we're expecting within the tumor itself.
Great. And then Dr. Taylor asks, for Christopher, GBMs are very heterogeneous. Is the spatial resolution of FUS comparable to targeted surgical biopsies?
That's another good question. We do plan, because of the spatial heterogeneity that you mentioned, we want to target distinct areas of the tumor in order to sample the molecular profile as we go along, sort of along this raster scan, for example. And so that will be very important in terms of translating this to the clinic and for precision medicine. So then we know which drugs work for which area of the tumor and which don't for other areas. And so that is something that we will continue to investigate as we progress and advance our technique.
Okay, and the final question also for Christopher was from Dr. Parker. And he says, nice talk. Can you comment on the range of FUS parameters that will work? And does it always work? Or are there parameters that just won't work?
Thanks, Dr. Parker. We have looked into different parameters for the mice. For the pigs, what we did was we increased the FUS pressure, changed the microvolts dose in order to make sure that our technique is very reliable. And for the mice specifically, we looked at different FUS pressures, so 0.5, 1, and 1.5, or a little bit medium and high pressure, And we do see that around the medium, about 1 megapascal of acoustic pressure, that we're getting really significant results of biomarker release compared to the much lower pressure. And so this is definitely going to be further investigated for different tumor types across different species, but this tells us a little bit more about how we can specifically tailor our technique towards a number of different applications.
That's great. Okay, so we're going to move on to a question from Dr. Minashima for Dr. Chen. Quite a small number of training data sets, but the results look pretty impressive. Any special treatments? Did you imply any special treatments when training the AI system?
That's a great question. And as Dr. Zacharczyk pointed out, we always want to collect more data. But here we do have a relatively small number of training data sets, although we did use transfer learning, and that means we used a network that was trained on a previous study, and that was also amyloid, and we did have more data sets there. And also we did use data augmentation, which means we flip the data sets, we do rotations, and we also train on a 2D basis. So that means although we only have 18 participants, we have around 90 slices per participant. So that will give us a good number to train on. But of course, more data is better.
And I had a question for you as well about, so you used a PET MR, I believe, to implement this deep learning. Can you use PET CT images instead? Is that possible?
We did see that MR helps because of its exquisite soft tissue contrast, because we do want to see the tracer uptake in the cortex well. Although we did also try PET-only methods, and with that, our lab mate tried to use a more powerful neural network to do that task, which is the generative adversarial network, or GAN, that you might hear a lot about in the literature recently.
Okay, thank you. So the next question for Dr. Smart, also from Dr. Minashima. He says, impressive study. One question, how do you validate transsynaptic acetylcholine concentration measured by PET? And can you do microdialysis or in some sort of comparable technique in a non-human primate?
Yeah, that's a great question. So microdialysis in monkeys would be the ideal validation for this, I think. So far, we've kind of done everything we can to not have to do that. But so what we've done so far to try to validate this is to validate our radio tracers really thoroughly so that we can kind of rule out other things that could cause the effects we're seeing, like differences in non-specific binding, that kind of thing. So we're really confident on that side. The indirect support for our interpretation comes from doing the studies in multiple systems as well, so that we can't pin it to just weird behavior of one specific radioligand. It seems to be across the system. And then also looking at different doses, we do see the dose response relationships that we'd predict from our models. So that's all pretty encouraging. Eventually, microdialysis in monkeys would be a great way to validate this, although there are caveats there. Microdialysis of acetylcholine especially is pretty challenging and really dependent on how you treat your dialysate. So quantitatively, it might be difficult to make those comparisons as well as we would like to. I think a more tractable way to do this might be to start looking in patients. I think Alzheimer's or Parkinson's disease patients would be a great way to do this, because we have some really specific predictions we can make about how these relationships should be different just based on cholinergic deficits that are pretty well validated to be in those patients and specific to the cortex in a lot of cases. So that's probably where we'll go next. And then eventually we might try microdialysis down the line.
So can these methods be applied to other neurochemical systems using other tracers?
In principle, yes, and that is also something we'll explore. With acetylcholine, it really helps that we know that we have this specific and kind of binary regional difference. When we're looking at kind of gradients across the brain, I think that's going to be a lot harder to tease apart and to be confident about what we're looking at. But the relationships should be the same for any tracers. So in principle, yeah.
Great, thank you very much. So the remainder of our questions are for Dr. Agarwal. Dr. Benishima asked, your approach to combine CNN and model-based approach is intriguing. His question is, CNN and model-based approach probably does not need to be applied in the same spatial dimension. That is, the CNN can be applied locally and the model-based can be applied to the entire space, or vice versa.
Yes, that is true. So in fact, you can apply that, but to ensure the data consistency, at the end, you need entire image at once. Then only we can take the entire Fourier transform and the mask. So yes, this is true that we can train the CNN separately and then do the data consistency. Yes, there are both kinds of methods which do like separately pre-train the CNN and then apply the data consistency. That's true. Thank you. Yeah. Okay,
great. And then the next question for you would be from Ganesh Adlaru. And he says, nice talk. Have you looked at any dynamic data reconstruction using your MODL approach?
Dynamic, in our lab for the cardiac images, yes, some students are working on that one as well. Yeah, so there are extensions. So there are compressed based algorithms in our lab, and now some students have extended them to deep learning based approaches for the dynamic data set. Yes. In particular, there is one approach in our lab, which is like model storm, which is an extension of model, and that combines with the compressed based approach storm. Yes.
Great. Okay, and then a final question for you from John Tamir, who was a imaging elevated former presenter from a previous year. Says, great talk. I have a question about learning the sampling pattern. Since your original data were acquired on a discrete grid, are the results influenced by the simulated non-Cartesian forward model? And have you tried using the sampling pattern prospectively?
So no, this is a simulated experiment. This is true. This was a limited study for the 1D sampling mask. And yes, data was acquired originally on the discrete grid, but we are planning to do it for the continuous case as well. We are working on it. Yeah. Currently, it is limited to simulated settings. Yes.
Okay, thank you very much. And in the interest of time, unfortunately, we need to move on. Oh, sorry, I did want to ask Greg if he had any final questions, but we're now running out of time. No, you're okay? Great. All right, so first I'd like to announce the winner of the Emerging Investigator Award. And this year, our Emerging Investigator Award goes to Christopher Pacha. Thank you, Chris. That was a great talk. And yeah, so you are our winner this year.
Thank you so much. Thank you, everyone.
Okay, so I would also like to have a huge thank you to Dr. Saharchuk and all of our excellent presenters today and throughout the entire symposium. I would like to just say that through these very difficult times, it's so encouraging that we can still come together, albeit virtually, to discuss science and medicine and to showcase new ideas and highlight the next generation of talented young stars in the field of imaging sciences. I hope all attendees will agree that this has been a very inspiring 3 days. And with that, we will conclude this year's University of Utah Department of Radiology and Imaging Sciences Imaging Elevated Symposium. And I hope sincerely that we can all be together again in the near future. Thank you.
Thank you. Fantastic organization and really inspiring talks. Have a great weekend.